The Minimally Invasive Gynaecologic team at Laval University in Québec present a technique for abdominal cerclage at 15 weeks of gestation after trachelectomy. Here are some key tips and tricks for abdominal cerclage during pregnancy. We present a post-trachelectomy case at 15 weeks and highlight the key surgical steps. Nearly half of women diagnosed with cervical cancer are younger than 45 years, with a significant proportion wishing to preserve their fertility. Currently, for tumors less than 2 cm, fertility-sparing surgery is considered safe and is offered as part of standard practice. Moreover, in cases of recurrent miscarriages, preterm birth, or failure of vaginal cerclage, the IVF-Conceived recommends that women who have undergone a trachelectomy should receive an abdominal cerclage. Additionally, the placement of an emergency cerclage may be considered for women whose cervix is dilated less than 4 cm without contractions and who are under 24 weeks pregnant. The patient is 37 years old with a history of trachelectomy. This is her second pregnancy, achieved through IVF following a spontaneous early miscarriage. At 15 weeks of gestation, the cervical length measured 17 mm, with insufficient cervical tissue to allow for a vaginal cerclage. Step 1. Preparation with a gravid uterus. To obtain adequate exposure, the assistant on the patient's right uses a lever retractor designed to be non-traumatic for the gravid uterus. The operating table tilt is adjusted as needed throughout the procedure. We performed a Hasson open technique to insert the laparoscope, minimizing the risk of uterine trauma. 2 5 mm trocars were placed in the iliac fossa, and one 11 mm trocar was positioned 3 finger breadths above the umbilicus. Insufflation pressures do not exceed 15 mm of mercury. In the context of pregnancy, monopolar current is avoided in favor of advanced bipolar energy. Additionally, the patient received indocin and was positioned with pneumatic compressing stockings. Step 2. We want to expose the isthmus and the uterine artery. First, the vesico-uterine peritoneum was inside and the anterior lift of the broad ligament was opened. The lever retractor continued to provide exposure in the least traumatic manner possible. The bladder was then dissected and gently reflected inferiorly using blunt dissection. The posterior lift of the broad ligament was fenestrating using a grasper through the medial trocar. Then the incision is distincted cranocaudally by blunt dissection. The same was done on the right side. Tilt and trendeler burr are key to optimize exposure here and equally important during cerclage placement. Following these dissection steps, the uterine artery was identified along its tortuous course. Step 3. Placement of the cerclage. A non-absorbable monofilament suture made of polypropylene, size 1 and 75 cm in length was used. Identify the isthmus. Gentle pressure in the anterior fornix can help determine the correct level for cerclage. Avoid traditional manipulators. Insert the needle between the uterus and the uterine artery. Some bleeding is common. Stay calm. It usually stops when the cerclage is tied. The suture was then passed through the previously fenestrated left broad ligament, encircling the uterine fundus. Notably, there were no adhesions in the posterior compartment. The suture was then passed through the window in the right broad ligament. Finally, the needle was passed again, medial to the uterine artery. 1 or 2 sutures can be placed around the isthmus. Step 4. The rudder knot and peritonealization. The rudder knot eases the application of the rad pressure. It allows sufficient tension without tissue strangulation or ischemia. It is then secured with 4 additional intracorporeal knots. Then, we confirm that the suture is placed at the correct level. Peritonealization of the cerclage suture was performed using a barbed suture. The vesico-uterine peritoneum is carefully closed to seal the fenestration of the broad ligament. Since vessels are more prominent during pregnancy, it's important to use hemostatic agents if bleeding occurs. At 36 weeks, the patient underwent a C-section following premature rupture of membranes and delivered a healthy newborn. The cerclage was left in place for the following pregnancy. In conclusion, due to the limitations imposed by the gravid uterus, carefully planning is required for optimal exposure. In step 1, we begin by placing the trocars higher using a Hasson open technique. Insufflation is limited to 15 mm of mercury and monopolar energy is avoided. A hepatic retractor ensures gentle and safe exposure. Step 2. Next, we dissect the vesico-uterine peritoneum and both leaves of the broad ligament to identify the uterine arteries. Moving on to step 3. Using a vaginal manipulator, a monofilament suture is passed medial to the uterine arteries. The cerclage tension helps stop any bleeding. Finally, in step 4, with the cerclage in place, a rudder knot secures the suture, followed by 4 intracorporeal knots. A peritonealization of the cerclage is performed. Let note that, according to the literature, it might be more optimal to perform this technique outside of pregnancy for better pelvic exposure, as well as to avoid surgery under general anesthesia during pregnancy. I would like to thank your entire team for their cooperation. Thank you for watching.